Hello, and welcome to the Parkinson's Foundation Wellness Wednesday, Dizziness and Vertigo and Parkinson's. I'm Annie Long, Program Manager for the Georgia, Carolinas, and Tennessee, Kentucky chapters of the Parkinson's Foundation. I'm tuning in today from Alpharetta, Georgia, and we warmly welcome you to the program. We'd love to know where you are tuning in from. Feel free to share your location by typing it into the Q&A box. You are not alone, and your Parkinson's community is here with you today. The Parkinson's Foundation will be hosting virtual events each Monday, Wednesday, and Friday of the week. To learn more and to register, please visit parkinson.org/pdhealth. We hope you can join us next Wednesday, December 16th at 1 p.m. Eastern Time for Supportive and Palliative Care, the Best Kept Secret in Medicine, featuring Dr. Benzie Kluger from the University of Rochester Medical Center. Supportive and palliative care is focused on helping people live as well as possible for as long as possible, and is highly relevant for people living with Parkinson's disease and their families. For more information and to register, please visit parkinson.org/pdhealth. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. I would like to thank Light of Day Foundation for their tremendous support. We'd also like to thank today's program sponsor, Theravance, for their support. The Parkinson's Foundation provides families with free resources, including our website, parkinson.org, educational books, webinars, podcasts, a hospitalization kit, and our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson's specialists. To learn more about our resources and our upcoming virtual events, remember to visit our website at parkinson.org and call our helpline at 1-800-4PD-INFO. All right, without further ado, I'm excited to welcome our first speaker, Dr. Julie Kurek. Dr. Kurek, a second-generation American, completed her undergraduate studies at Brown University and attended New York Medical College. She completed a fellowship in movement disorders at the Cushing Neuroscience Institute at Northwell Health in New York. Her passion is to optimize the quality of life for those living with Parkinson's disorders. This means using a holistic approach, addressing not only the motor, but perhaps more importantly, the non-motor symptoms these individuals face. To that end, she lends a sympathetic ear and provides not only the latest therapies, but education as well. Her hope is to leave you hopeful. So without further ado, Dr. Kurek, please take it away.
Thank you, Annie. I'm excited to be here today and talk to you guys about dizziness and Parkinson's disease. This is a topic that's near and dear to my heart, and that I have a conversation with patients almost every day. And I find that's an area of a lot of needed education, both for patients and their families, but also for medical staff as well, for your primary care provider. So when we talk about dizziness and vertigo, we're broadly speaking about 4 types of sensations. There's vertigo, which is this strong sense of the room spinning. There's disequilibrium, where people feel describing a little bit off balance or steady or wobbly. And then we have lightheadedness, which is more of a kind of a woozy feeling disconnected. And similarly related to that is that presyncope, where you feel faint, that you feel like you might just pass out. And the most common of those sensations and causes in Parkinson's is something called neurogenic orthostatic hypotension. And I know that's a mouthful, but neurogenic means it comes from the neurologic system. Orthostatic, orthos from the Greek for upright or straight. And hypotension meaning low blood pressure. And from now on, I will be referring to that as NOH, simply because it's a mouthful. So I know these pictures are a bit disturbing, but they do demonstrate the effects of low blood pressure in Parkinson's patients. And I put this here to kind of grab your attention and kind of hammer home the point of how important this topic is. It's overcoming a lifetime of conditioning where we're told that high blood pressure is bad. You go to see your primary care doctor and you hear about lowering your blood pressure, commercials, etc. And in general, for most people, that's true. But in Parkinson's disease, I see far more worse effects from low blood pressure than too high. I don't see any issues from the high, but definitely see injuries, fractures, and even just decreased quality of life that happens as a result. So my goal with this talk is that if I can prevent an injury like this in one of you guys listening, I will be a happy doctor. So what is orthostatic hypotension? It is defined medically as a fall in blood pressure that happens when you stand up. And the numeric measurements, your systolic blood pressure, which is your top pressure, for example, you get 120 over 80, the 120, if there's a drop of more than 20 points. And for the bottom number, which is your diastolic blood pressure, if you have a drop of 10 or more points. And this occurs when people go from sitting to standing or lying down to sitting or standing. And it's quite prevalent in Parkinson's. About 10 to 65% of patients have it. It's more common the longer you've had Parkinson's. And it's a common overlooked cause and quite treatable. So why does this happen in Parkinson's? So we know it's a systemic disease. It affects many things. And one of those things is our autonomic nervous system. So our autonomic nervous system helps us do all those things we don't have to think about, like digesting and urinating. And it controls our blood flow throughout our body. And if the autonomic nervous system isn't working well, then you're going to have your blood flow patterns are going to be disrupted as well. So this is a picture just to kind of give you an idea of what this looks like. So I want you to look at the person laying flat, and the red line in the middle represents their blood and their blood pressure. And gravity is exerting equal force horizontally across all parts of the body. But when someone stands up, you can see the head is much further from the earth than the feet. And gravity wins at some point. Blood pressure drops, and it's much easier for the blood to pool in the legs than have to work and go up the head. So this is just a quick kind of demonstration of what happens. So you're lying down, and then you stand up, and blood pressure falls. And this happens to everyone. It could be a matter of degree. But what happens is that we have receptors and sensors in our body that can detect that, and they send signals to the brain, and in turn, we have a reaction. Our heart rate increases, and our blood vessels constrict, and our blood pressure increases to compensate for this drop so that you don't feel dizzy. Unfortunately, what happens with Parkinson's is that this response is delayed or not occurring as vigorously as it should. And why do we then have the symptoms from this low blood pressure? Well, the brain accounts for 3% of your body weight, but it receives about 30% of the blood supply. The brain requires a lot of blood because blood carries oxygen and glucose. And you think of your brain as the command center, and it's doing a lot of things, kind of looking over and making sure things are running. So it's pretty greedy. And if it doesn't get as much of those things as it wants, it kind of acts up and it starts to shut down a little bit. So that's where we start to get symptoms of maybe some blurry vision or just feeling off. And the brain tries to protect you and gives you symptoms that make you want to kind of sit down and restore the blood pressure to it. So how do we recognize what would be the symptoms? So the key is upon standing, because any of these symptoms that occur sitting or at a constant can be something different. But if these symptoms occur with standing or worse in the morning, you're probably looking at neurogenic orthostatic hypotension. So feeling dizzy. Very commonly, people say they feel lightheaded or faint. Sometimes it can be very vague, like I'm just unsteady on my feet. I feel tired, I feel weak. You can imagine the brain, if it's not running on all full cylinders and getting the top tank of gas as it wants, these can be symptoms that happen. People will describe and they'll tell me, I have difficulty thinking. My vision is blurry, I'm sweating, there's some nausea. And this is a symptom I actually learned about in presenting this talk called coat hanger pain. And it's an invisible symptom and it's often misdiagnosed as a spinal problem. So in that pattern where you see the hanger, people have pain at the back of their head, neck, and shoulders. And that's from a lack of good blood flow to those muscles. So this is a picture of how a blood pressure is usually checked, right? You go to your doctor's office, you're sitting, they check your blood pressure and your heart rate, and that's it. The problem with this is that we do not live our lives in this sitting position. We move around and our blood pressure moves along with it to compensate. It's a dynamic thing, and that's not captured with one read when someone's sitting. Furthermore, the blood pressure reading that you get might not be a good representation of what your average blood pressures are. A lot of people, when they come to the doctor, they're a little bit on edge. You might have had trouble getting a parking spot, you're running late. There's a phenomenon called white coat hypertension, and blood pressure can be a little bit more elevated than it is normally. What that means is that sometimes doctors may be overly aggressive in lowering that blood pressure. So it's something to keep in mind. So if sitting and checking it doesn't work, how do we check? So this is the proper way to check for orthostatic hypotension. And I will tell you right now that even people in the medical community do not know how to do this properly. We'll ask someone to do it, and a lot of times it will not get done. In our neurology clinic and movement, our nurses are trained and very familiar, but what you want to do is have a person lie down, and you're just going to lay there for about 5 to 10 minutes to kind of allow things to equilibrate. And then you're going to check the person's blood pressure and pulse. Once you've done that, you have the patient sit, and you sit there for about 3 minutes, and then you check the heart rate and blood pressure again. And we do that one more time, having the patient stand. If they need some assistance or need to hold on to something, 3 minutes is a pretty long time. So at the end of those 3 minutes now, you're going to check the heart rate and blood pressure again. So this is a very sensitive and diagnostic tool. It is inexpensive, it's easily available, and it's cheap. The problem is that it's very time consuming. It takes about, you say minimal, if you do that correctly, about 9 minutes. And you know, if you're going to your doctor's appointment, there's more and more of a rush and pressure, seeing patients in and out, and there isn't necessarily time to do all of that. But I would want to emphasize that to really get true numbers, you want to have that delayed reading of 3 minutes. Now, those numbers are used to diagnose someone with the orthostatic hypotension, but I just want to give a note of caution that more important than any number is how you feel. So if your numbers aren't necessarily reflective of what you're feeling, we're always going to pay attention and see, based on what you're telling us, that you might have this, and we call that symptomatic hypotension. And this is true for both the diagnosis and then following you throughout the course of your treatment. We may be giving you some medicines and your numbers may not change all that much, but if you're feeling a lot better, that will be reassuring. So what can you do to help your doctor learn more about you and to understand your blood pressure as well? Since it's not always possible to do those long blood pressure checks in the office, one thing you can do is keep a blood pressure diary at home. And this is good too, because you can do this over a course of time, which will be more reflective versus a simple snapshot or moment of time at your doctor. And it doesn't have to be an elaborate diary, maybe just checking a few days, anywhere from 4 days to a week. And I would recommend checking your blood pressure at different times of day, for example, in the morning and in the afternoon. And the key would be not to just check the blood pressure and your heart rate, but to test it in at least 2 positions. You can go from like lying, and then stand, but make sure to stand for 3 minutes and then check those numbers again. If you bring that information with you, it'll be very helpful in your discussion with your doctor about making treatment decisions. So say you're diagnosed with the OH, what do? So first things first, before we add anything, we want to look at, is there anything we can get rid of? Anything we can eliminate? We want to think about factors, not necessarily medicine, that we can control, lifestyle modifications, and then see if we need to add anything. So makes sense. If you have trouble with your blood pressure hanging out too low or dropping, it makes sense to remove or modify medications that can cause a drop in blood pressure. It would make sense, of course, that antihypertensive agents or blood pressure pills would be a common cause. Beta blockers, sometimes we have to be careful. We can't necessarily get rid of medications like metoprolol. Sometimes people need that because of cardiac conditions, atrial fibrillation. And these are just a list on the left of different blood pressure names that might be familiar to you. You also want to think about diuretics, otherwise known as water pills like Lasix, hydrochlorothiazide. If your blood pressure is dropping a lot, we might not want to be aggressive and want to remove that. Another thing to think about that might not come to mind right away is prostate pills, such as tamsulosin. Those might need to be removed, and you might need to have a conversation with your doctor about that. Also, medications for erectile dysfunction. Those will cause vessels to dilate, and as a result will lower blood pressure as well. So one group of medications that might come as a surprise to you are your Parkinson's medications. It doesn't seem fair, but yes, the dopaminergic agents can in fact. Dopaminergic agents are great for motor symptoms. There are two symptoms that it can actually aggravate, one being constipation and two is drops in blood pressure. So if you're being started on your medicine for the first time, or you're going up on your dose and you're feeling more dizzy, this might be the cause. So dopamine agonists are a little bit more guilty of this than levodopa. So those are medicines like pramipexole or Mirapex, Apokyn, Nupro. So if you're experiencing this, discuss it with your treating physician. And it's a little bit, I put a double whammy because as your disease progresses, neurogenic orthostatic hypotension tends to get worse. At the same time as it's progressing, you also need a higher dose of medicine. So it's something to definitely to keep an eye out for. Some other medications to think about is quetiapine or Seroquel. We'll often use this in the evenings, particularly to help with visual hallucinations, sleep, or some behavioral issues. And you also want to think about things such as insulin and tricyclic antidepressants, which also have effects on blood pressure. So I say it's okay. So I often have the discussion about discontinuing or reducing doses of drugs. And of course, I want you to discuss this with your primary care provider. Ideally, we work together as a partnership, a team in treating you. But I just want to caution you too that physicians in medical school, et cetera, we're all trained to think lower blood pressure. It's a kind of a knee-jerk reflex. So it's really unorthodox and a little bit difficult for some physicians to think about allowing blood pressures to run very high. They worry about things like stroke or heart attack. And what I tell my patients is it's okay. We have to be okay with high blood pressures. And I often get asked, well, how high is too high? And I would say it really depends on the person and other comorbid conditions. But for a lot of people, I say it's okay if your higher number goes up to 200. Because I have some people who will drop 80 points. Remember, the definition is a drop in the top number of 20, but it can be higher than that. I have people who drop 80, 100 points. So if you start at 200 and you drop to 120, you're still at a number that can perfuse your brain. So, and like I said before, people end up getting hurt a lot more with these low blood pressures than the high ones, at least in my patient population, in my experience. So what are some things after kind of removing any aggravating medications. What are things we can do to help ourselves? So we just had Thanksgiving. You know what it's like to sit around and have that big meal, our stuffing and sweet potatoes and pie, and everyone wants to take a nap after that. And then you're sitting there and maybe you're having a beer and watching football, and when you get up, you notice you're really dizzy. So if you know you're going to be sitting for a long time, I recommend maybe getting up every once in a while. And simple maneuvers I can do while you're sitting, like pedaling your feet and kind of squeezing your muscles. I'll talk a little bit more about that later. And dehydration, especially when you're sick, you don't think about it, you need to kind of hydrate to keep your blood pressure up. So heat exposure, we're in Georgia here, so there's two things. You have some insensible water loss, but also in the setting of heat, your body wants to cool off. So your blood vessels, rather than constricting, they dilate, and that's a way for it to release heat to the outside. And, you know, our vessels are just pumps that are, you know, pushing blood to our brain. And if they, you know, widen, it's just physics. The blood is just kind of drained to the bottom and gravity wins. So also excess, you know, straining, physical exertion, and also straining during while urinating or a bowel movement. So what I recommend, rather than having a big meal, is eat smaller, more frequent meals. When you have a big meal, think about it, you have to digest, so your body diverts a lot of the blood to your gut. So that's less blood that is kind of in reserve for the brain. And, you know, try to stay cool. If you're going to be out for a while, come indoors for a little bit, drink a lot of water. And like I said, if you're sitting, kind of try to move around a little bit. And then if you're feeling really dizzy, there's some quick maneuvers you can do to lessen these symptoms. And I'm sure the other speaker, Kathryn Lewis, might have more to say about this, but here you can use gravity to your advantage. So if you're dizzy, you can lie down and actually have your head below your heart level. And so the blood, it'll be easier to get to your brain. And other little things, your calf muscles, when you squeeze your calf muscles, it actually squeezes the veins, the valves in your veins, and it kind of milks blood back to your heart and to your brain. So there are different things you can do to kind of help yourself feel better. My number one advice for patients is just take your time. There's no rush, you know, especially, you know, I feel my population is older. You live your whole life, enjoy, especially getting up in the morning. Take your time, luxuriate in it. You know, roll your wrists, your ankles, stretch, move around. I recommend sitting on the edge of the bed for a couple minutes and kind of getting your bearings. And one trick I find helpful is keeping a tall glass of water at your bedside and just drinking that first thing in the morning. So hydrate. I think we need to drink more than we think we do. Minimum 64 ounces daily. And if you ever feel dizzy, you can do what's called a water bolus treatment. Just drink a lot of water. It'll help increase your blood pressure for a while. And then opposite of what most doctors also recommend, I tell you to eat more salt. So salt is helpful in that it helps you retain fluid. If you think you eat salty foods or potato chips, you get bloated. If we just drink plain water, we can end up just urinating it out, but the salt helps it stay in our blood vessels. And this kind of bloat is a good thing in this case. I would just say be careful if you have heart failure or a history of fluid retention. And this comes up, and I wanted to acknowledge it, that I find that patients often don't drink as much as they should, because whether consciously or subconsciously, they know it'll make them run to the bathroom more often. And you're already struggling with urinary urgency or incontinence. And on top of it, there may be some postural instability. So it becomes a little bit uncomfortable. So I would say the solution for that would be just, one, be aware of it. And it's not an easy balance, but make sure you're not depriving yourself of fluid for this reason. For the bedtime, a lot of people want to avoid nocturia or getting up in the middle of the night when it's already difficult, maybe getting back to sleep after you go. I would say for men, it's easy to keep a jug at the bedside. It also prevents a fall from walking over to the bathroom, or for women, you can have a commode. And you can also front load your fluid, drink more earlier in the day and less later. And, you know, if urgency and frequency are issues, there are also medications to address that. And there's also some procedures. There's also Botox to the bladder, which helps calm it down. So there's ways to address this. So definitely talk to your doctor about it. And just like I said with the salt, you will urinate less if you're drinking fluids with electrolytes. So something like a Gatorade or something like that that has potassium and salt, which stays with you rather than just kind of running out of you quickly. Other things to do are compressive garments. So compression stockings, the higher they are, the more effective they are. They can be a little bit tricky to get on, so there are some instruments that help to do that. And don't be afraid to ask for help. Also, abdominal binders. So when we've tried all those things and we still need more help, that's when we turn to medications. So next I'll be describing the 4 medications that I prescribe most commonly. First one is Fluorocortisone, also known as Florinef, and this helps promote salt and water retention. So you have more fluid in your blood vessels, and more fluid kind of helps raise that blood pressure. Midodrine has a different mechanism of action. Rather than increasing the supply of blood, what it does is has the blood vessels squeeze. So it can squeeze what you have more easily against gravity to your brain. Florinef is prescribed once a day in the morning, and midodrine is usually about 3 times per day. Another drug is pyridostigmine or methanol. This helps kind of the chemical messaging at your baroreceptor synapses. That's what's detecting your blood pressure. And it can be effective for less severe OH, and it's less likely to worsen the supine hypertension or high blood pressure when you're laying down. And last here is Droxadopa, brand name Northera. And what this drug does is that in the body, it becomes something called norepinephrine. And norepinephrine is another chemical which causes the blood vessels to squeeze and help maintain your blood pressure. It might be interesting to note, just like you're missing dopamine, you take levodopa, and norepinephrine is missing, so you're taking Droxadopa, which turns into norepinephrine. In the body, dopamine is normally converted to norepinephrine. So it makes sense that if you're low in one, you're low in the other. So we supplement this as well. The caution with all of these drugs is that we don't want our blood pressure too high when we're laying down, have a high force of blood pressure going to the head. This can result in some headaches and that kind of thing. What I recommend in general is try to take your blood pressure meds at least 3 hours before going to bed or lying down. Recommend elevating the head of the bed. That could be with 3 or 4 pillows or putting a wedge. And a quick, easy way to lower your blood pressure is putting, you know, those old hot water bottles, you put one of them on your belly, and the heat, like I mentioned, it causes your blood vessels to dilate, and that's centrally pulls it to your belly. So that's a quick way to bring your blood pressure down. In some cases, I never do this, but I can imagine in some cases it might be warranted to take a short-acting drug that lowers blood pressure. I would just be cautious with that because often you don't want it too low, especially if you have to get up and use the bathroom at night. So it's tempting to always blame it on the Parkinson's, or if you have Parkinson's, it seems like everything relates back to that, but that's not always the case. Just because you have Parkinson's doesn't mean that these other things can't occur as well, so we want to keep those in mind as well. Some patients with Parkinson's have something called a deep brain stimulation device inside their brain, and dizziness can occur as a result of the procedure. And sometimes the programming, if this occurs, go back to see your neurologist and troubleshoot, and we might need to change the settings on there. Another common cause of feeling unsteady is peripheral neuropathy. Peripheral meaning kind of your periphery, your hands and your feet, and neuropathy meaning those nerves are not, they're damaged. And sometimes that happens as a result of diabetes. It could just be a result of age. And I liken neuropathy to kind of the antenna on an insect. If they're not working well, our feet constantly send signals to our brain about where we are in space. And if our brains are not getting those signals from our feet, we're going to feel more unsteady. That's one of the reasons when people have neuropathy, if they walk in the dark, they have more trouble and more falls, because in the daytime, we can use our vision to compensate. To be able to walk and feel steady, we basically need 5 systems in our body to be intact. One of them is our vision, our eyes, our ears, our inner ear or vestibular system, and then our brain, our balance center. And then we need to have strong muscles and joints, and last, these nerves. So vertigo, what I was describing before was more of a lightheadedness. With vertigo, it's more of a almost violent room spinning, kind of around you rather than within you. And it's very common. It affects as many as 40% of adults over 40, and the number just increases with age. So there's many causes for this, mainly inner ear. There's an entity called benign paroxysmal positional vertigo. And if you see these in the inner ear, these semicircular canals, they're at 90 degrees with each other, and there's fluid that moves in there to kind of tell us where we are in space. Sometimes little particles get loose and kind of jingle around in there, and that can make people feel very dizzy. Also, if you have an infection, whether it be viral, like vestibular neuronitis or otitis media, where you get fluid in the ear. Some people have something called Meniere's. Those will all be causes of vertigo. You can also have central nervous system causes, vestibular schwannoma. So I had an interesting case last week. I had a woman who came to see me. She didn't have Parkinson's, but she had significant orthostatic hypotension. And she had also been seeing a cardiologist, and we had been treating her for this. She also had very severe peripheral neuropathy. She has a condition that worsens it. So between her drops in her blood pressure neuropathy, it made sense. That seemed to explain why she was feeling off balance. Yet when we put her on medications to treat that, she didn't get better. In fact, sometimes she said she felt worse. And she had an MRI of her brain, which was normal, but done a little bit later and with special cuts, we discovered that she actually had a schwannoma. So sometimes it seems that you have enough, but if someone's not responding and something seems a little bit off, then that would be a good time to consider other options or causes. If you have a sudden onset of dizziness, especially with any other kind of symptoms like weakness or slurred speech, you want to think about a stroke or a transient ischemic attack. And just in general, there's other conditions to consider. If you have heart issues, that can make you more prone to faint. If you're on any medication, some class of antibiotics are very known for causing inner ear issues and making you dizzy. And it may come as a surprise, but anxiety and depression can sometimes manifest as dizziness. So as you can see, there's a lot of causes and reasons, but in the Parkinson's population, it's the drop in blood pressure. I will say that would be the number one. But always remember, it can be something else, and you can have both. So if you're interested in learning more about dizziness and vertigo and Parkinson's, and maybe participating in some trials and helping out with future treatments, I would encourage you to go to this website here and participate. So at this point, I know there's some questions from the audience, which I could go ahead and address now. These were submitted. So one was, does Parkinson's cause dizziness without warning? I would say no. A sudden onset of dizziness without warning, that sounds something more consistent with benign positional vertigo, where turning over in bed or something like that will cause the dizziness to come on. I would say it's a little bit more gradual in Parkinson's, though if you're, it's severe and in end stages, it might come on more quickly. But in general, I would say no. And second question here is, how do I control extreme loss of balance? I would say the first thing would be to figure out what is the cause of your loss of balance, because the treatment will vary. If it's neuropathy, the treatment will be helping you to work with maneuvers with your physical therapist to kind of do compensatory moves to avoid falls. Whether it's an inner ear problem, you might need some kind of medication, vestibular therapy. There's special maneuvers that you can do to your head to kind of deal with the dizziness. So, and if it's your blood pressure, then you would treat that with drugs. So at the end of the day, I would say you identify the cause, and then you can come up with the treatment. And that might be, it may be multiple causes, and you might need to treat each individually. So I like this question. How do I get my mother to use her walker so she won't have a fall? I can't help but think, how do we get anyone to do anything? I know I can't get my mom to really do something if I tell her to. So, I like to say I present options and people make decisions, but, if you present with the evidence and the numbers, like those pictures I showed you in the beginning, the consequences of not using a walker are not inconsequential. People suffer loss of consciousness with falls, head strike, ending up in the emergency room with hip fractures. The morbidity, the mortality of women 80 and above after having a fracture, within a year, most women pass within a year after a fracture. So it is extremely dangerous. So I would kind of hammer that point home. And I find that once people get used to a walker or the idea of a walker, I think there's a little bit of a pride thing initially where people feel like they're giving in by using it. But I actually say that this is a way to empower you. A lot of people feel more confident and safe when they're walking with it, and they end up walking more and strengthening themselves and getting better. We all know how important exercise is for your health and treating the Parkinson's. So I would kind of use that carrot approach too, looking at the benefits of it. So another question. I also have Meniere's disease, and I'm struggling to treat my dizziness and imbalance because I don't know which is causing the constant imbalance feeling. So I would say there's clues. If it's orthostatic hypotension, whereas other diseases like Meniere's, you might have ringing in your ears. You might notice these symptoms come on when you're turning over in bed. So they'll present differently. And what I would recommend is getting a full evaluation with an ear, nose, and throat physician. So another question here. I am currently on Sinemet, Comtan, and Rasagiline. My question is, the meds are lowering my blood pressure. Would that be causing my dizziness? Mornings are worse. The doctor I go to has recently made these changes in my meds. I am being groomed and tested for possible DBS in the future. So yes, is the short answer to your question. Those meds can be lowering your blood pressure and making you more dizzy. And the big clue in your question here is that mornings are worse. That's a big clue that's due to low blood pressure. And if barring anything new, that being the only change, yes, it would be due to your medication. And I would say it's important to treat that. I wouldn't necessarily stop one of these medications. I wouldn't, because not at the expense of your motor well-being, but we might need to add on something to boost your blood pressure a little bit. And I think that's especially important if you're considering deep brain stimulation, because deep brain stimulation is a fantastic technology, amazing benefits, but it's helpful for what it's designed to do. And there's a few things it does not help with and can actually worsen. And one of those things is balance. When people feel more unsteady after it. So you would want to get that sensation of feeling dizzy or off balance due to meds under control before undergoing DBS. So is it wise, this is the next question, is it wise to wait for screening for Parkinson's until after COVID has settled down, or is it imperative to be checked as soon as possible? Well, I'd say the good news right now is that we have light at the end of the tunnel right now. There's a vaccine coming, and in general, I would probably recommend for you to wait. There are virtual visits happening, so if you'd like to talk to somebody about your symptoms, that would be possible. I would say it also depends on how severe your symptoms are. Regardless if you're diagnosed or not, I'd say one of the best things in general for you is exercise. If you can eat well and exercise, because right now there's nothing to slow down Parkinson's, the treatment is symptomatic. If you feel you're able to go about your business right now and function relatively well, I would say hold off for a couple of months. But if you're suffering, that has its own risks as well, and that might be balanced against going to see a doctor. So last question here. My dizziness or lack of balance seems worse at night in the dark. It's like my feet don't know where they are. Is this common? Yes, this is very common. Like I was referring to earlier, that's exactly what's happening. You probably have some neuropathy, which is very common. Most people over 60, 70, definitely over 80 have some neuropathy. It's a matter of degree. And you're not feeling the ground so well. And when it's dark, your eyes are not helping to guide you. So that is very common. So one thing you might want to have is maybe night lights around and different measures to help keep you safe while trying to navigate at night. So thank you very much for your attention and for your questions, and I hope you find this helpful.
Well, thank you so much to Dr. Kurek for that really informative presentation. We're going to now switch gears. We're going to have a shorter presentation now, actually looking at the treatment of things like dizziness and vertigo from a physical therapist standpoint. So as many of you guys know, exercise is hugely important, as is seeing a physical therapist. So next up, we have Dr. Kate Lewis. Dr. Lewis is a physical therapist who works at Bppv Rehabilitation Institute at Vanderbilt University Medical Center. She is a board certified neurologic specialist in physical therapy with advanced training in vestibular physical therapy. She's a graduate of Belmont University School of Physical Therapy in Nashville. Kate is passionate about caring for others and empowering individuals to gain ownership of their health. Physical therapy allows her the capacity to serve and encourage those who need it. So Kate, thank you so much for being here today.
Hi, thanks for having me, Annie, and Parkinson's Foundation members. It's an honor to be here. So I work with a lot of Parkinson's patients with neurologic dysfunction, vestibular dysfunction, and it's just really a passion of mine, a fun area to treat. So I'm really glad to be here. So we're going to talk about how physical therapy can help in the management of dizziness and Parkinson's. Let's see if there we go. So a lot of times vertigo and dizziness kind of get used synonymously, but as was pointed out earlier, they are a little bit different. Vertigo or dizziness really is the illusion of movement. So it feels like we're moving when we're not. Dizziness is kind of an umbrella term, whereas vertigo is going to be that actual spinning sensation, that rotary component, whether it's an individual spinning or it feels like the room is spinning. And when you have vertigo or you have dizziness, either one, you're going to feel some imbalance, right? That's kind of an obvious statement. The dizziness can be caused by a number of things. As was alluded to previously, you can have dysfunction in your inner ear. You could have an inner ear infection. You can have kind of a brainstem or cerebellar dysfunction. We would refer to that kind of as a central dysfunction, and then kind of a general systemic condition. So there's a lot of things that can cause dizziness. I kind of link it to, there's a lot of things that can cause pain. And pain's kind of an alarm signal for our brains that something's not right. Dizziness is kind of one of those things too, is it's a lot of things can cause dizziness. And it's an alarm system that something might be off that we need to address. Dizziness can occur in up to 30% of healthy adults. And some of the symptoms we see or folks experience are that blurred vision, eyes jumping, imbalance, dizziness with head or body movements, lightheadedness, and just disequilibrium and disorientation. And so dizziness occurs with Parkinson's. It's considered an early non-motor sign, and at times may be an early indicator of Parkinson's. One study found that in early Parkinson's, almost 50% of individuals had some kind of dizziness. When you look at the general Parkinson's population, up to almost 70% of folks have experienced dizziness sometime in their disease progression. Research has showed that degeneration in the brainstem, particularly the substantia nigra, where we have a decrease of dopamine, is associated with vestibular dysfunction. So one of the hallmarks of Parkinson's is that decrease of dopamine that occurs in the substantia nigra, which is in the brainstem. And so that area is really close to our kind of vestibular command center. And so we've seen that may be one of the reasons that we have dizziness in our Parkinson's patients, is because they're neighbors, and we have a breakdown pretty close to that vestibular command center. Different kinds of dizziness that we can see with Parkinson's patients kind of touched on, the last presentation touched on this, so I'm going to kind of go quickly through them, but just to kind of touch on that orthostatic hypotension, that's a huge one, and that's something that we're going to manage medically, but we can also do a few things in therapy to help with that, and I'll touch on that in a little bit. Dopamine agonists or medications that you're taking, some of the side effects can be dizziness. Benign persistent paroxysmal vertigo, or that Bppv, that's a positional vertigo. We'll talk about that a little bit more. A TIA or a stroke, a TIA is a shorter, not a full-blown stroke, but it's kind of a neurologic event that occurs prior to a stroke. Cognitive decline has actually been shown to be associated with dizziness. And then general central nervous system dysfunction. As therapists, as physical therapists, the length of someone's dizziness can give us a good indication of cause of dizziness. So benign persistent paroxysmal vertigo, that dizziness would generally last a minute, 2 minutes, definitely less than 5 to 10 minutes. But a dizziness that's coming maybe from a central nervous dysfunction, that's going to be a little bit longer of a dizziness. So it's important when you're talking with your physical therapist or you're kind of tracking your dizziness to kind of just keep a mental note of how long it lasts, because that really will help drive treatment to give us an indication of what's causing it. And so kind of real quick, orthostatic hypotension, we know that, we heard about it. It's a drop in blood pressure with position changes. It can cause that dizziness or lightheaded feeling, highly associated with older age, disease progression, and dopaminergic drugs. And so that's something that you're going to primarily talk with your physician about medical management. The dopamine agonists, they mimic the effect of dopamine in the brain, and research has shown that dizziness and orthostatic hypotension are side effects. Here's some examples of those. as well. And again, if we're on these, it's not an alarm system that we need to go off from right away. We just may need to change, maybe have a conversation with your doctor about some of the side effects you're experiencing. One of the big things is migraines. We can get vestibular migraines, and that can cause balance or vestibular dysfunction. And some of those symptoms associated with a vestibular migraine, sensitivity to light or noise, vertigo and imbalance, nausea and vomiting, and headaches. So that is something that would cause some positional vertigo as well, or some maybe longer episodes of vertigo. The TIA, like I talked about a little bit, that's caused by reduced blood flow to the brain. And that can cause lightheadedness or dizziness during the TIA or after, if an area of the brain was impacted that affects dizziness. And then research has also shown that a decrease in cognition is also associated with vertigo, interestingly enough. And then here's that Bppv, that's a big one that we see. It can cause vertigo in up to 11% of patients, which is quite a bit. It's the sudden sensation of spinning due to a position change. So you turn your head, you bend down, you look up, and you get that feeling of dizziness that may be coming from Bppv. And as was alluded to before, it's caused by some loose particles in a part of your vestibular system called your semicircular canal. And we'll kind of touch on this, but I always tell my patients, if you're going to get dizzy, this is the best kind of dizziness to get because it's very easily resolved. It's an easy fix. And so if you're slated in your life to get dizziness, this is the one that actually isn't too bad to get. And then when we talk about a central vestibular dysfunction, it's kind of what I touched on a little bit. The degeneration that occurs with Parkinson's can impact that central vestibular system or that central vestibular command center. And so we'll get kind of more generalized dizziness and vertigo, some balance difficulties, and a big thing would be dysfunction with those eyes. So maybe difficulty tracking, blurred vision, maybe some difficulty reading, things like that. So physical therapy and Parkinson's really go hand in hand. Physical therapy is, I'm a physical therapist, so I'm a big fan of it, but physical therapy is widely helpful for Parkinson's disease. So we work to improve movement patterns. And what that means is we're trying to improve walking and balance and strength and coordination and all the areas that we move. What we're trying to do is maximize function, optimize function, reduce fall risk, and prevent further decline. One of the best disease modifying agents for Parkinson's disease is exercise. We know that, we hear that a lot. And so physical therapy and exercise can really help to manage those symptoms. And there's even been research showing that exercise and physical therapy can help slow the progression of some of our more serious symptoms. So really exercise is super beneficial for Parkinson's disease. And that's true with the vestibular system as well. And so when we're talking about vestibular physical therapy, our goal is going to be to minimize that vertigo and minimize our dizziness. And so we have some principles of vestibular therapy: habituation, adaptation, and substitution, which I'll talk about and give some examples of. But what we're really trying to do is create some neuroplastic changes. So the brain is really cool in that it's able to make changes kind of globally. So we can actually develop new pathways and develop new ways of moving, and neuronal pathways new ones can be laid out if there's been damage elsewhere. And so we really want to tap into the plastic ability of the brain to adapt in order to maximize function. And what we're really looking for is long-term compensation for vestibular dysfunction. So regardless of what's causing our dizziness, our imbalance, we're looking to compensate for that loss in one way or another in order, again, to maximize function. So we're gonna look at balance. We're gonna look at proprioception, which is feeling where you are and where your body is in space. postural stability. So that's going to be our standing balance, our walking balance, you know, maintaining balance when we're doing kind of life. And then vestibular visual stimulation. So the eyes and the inner ear work together very frequently and work together a lot within vestibular system management. And so we're going to work on making sure that those two systems are talking and working together and there's not a mismatch. I'll kind of touch on that in a few slides on that interaction. And what we're trying to do is get all these sensory systems, our eyes, our sense of touch, and our inner ear all working together so that we can make long-term changes and long-term compensation. So some of the symptoms that we see with vestibular dysfunction, with dizziness, is that blurred vision, right? So that's going to be caused by a mismatch of the eyes and head not working together. So when we have normal vestibular function, we'll have equal and opposite eye and head movement. So what that means is when I turn my head to the left, my eyes should move in an equal and opposite direction to the right. That's called the vestibular ocular reflex. And when there is a dysfunction in the vestibular system, that reflex is off. There's a mismatch. And so we work to recalibrate that reflex and get those eyes and head moving together so that vision's not blurred. People will also complain of eyes jumping. Again, that's going to be caused by that mismatch of eye and head movement and or poor gaze stability. So the eyes may be moving a little too much or not enough. And so we're working on stabilizing that gaze. We're first going to do it when your head's not moving, and then we're going to progress to making sure your gaze is stable when your head is moving. And so those are things that your vestibular therapist will work on. People will complain of dizziness with head turns, and that can be caused by motion sensitivity, motion intolerance, that mismatch between the eyes and head that I talked about, and an imbalance. And so to treat that, we're going to work on walking with head turns. We're going to work on decreasing that sensitivity. We're going to work on habituation exercises, which is on my next slide. And then finally, we have people complaining of imbalance, and that's caused by this postural instability. And there's lots of different things that can cause postural instability. But it's also caused by the sensory systems not talking together, not integrating enough. And so to work on postural stability, we'll do static and dynamic balance exercises. So that's going to be, you know, standing on uneven surfaces, walking on uneven surfaces, walking with assisted devices, walking with head turns, working to improve the integration of these sensory systems. So here are those principles of vestibular PT that I talked about, the big four. So habituation is when we get the brain to stop attending to something that at one time was aggravating. So kind of like desensitization for aggravating movements. So if bending over, and again, this is not with Bppv, this is not with a positional vertigo. So let's kind of take that out. So let's say turning your head to the left makes you dizzy for 30 minutes every time you do it. So we would work on doing that motion, but doing it in a safe environment and kind of in a graded manner so that eventually turning your head would not be aggravating. So that would be kind of a principle of habituation. If we're talking about adaptation, we're talking about readjusting some of those vestibular reflexes I was talking about. So working on getting those eyes and head to move together at the same speed and magnitude. We talk about substitution, that's using other systems to kind of pick up the slack. So that would be if your eyes are not working the way they need to, or you have low vision, then we're going to try and boost up your sensory system, your sense of touch and your balance to kind of substitute for the loss or dysfunction you have in another system. So that's going to be using maybe an assisted device or additional lighting when you get up and go to the bathroom at night, or doing things to kind of make up for a dysfunction that we can't change. And then the long-term thing we're looking for is compensation. So we're looking for those neuroplastic changes so that we can optimize function. So here's some examples of different exercises that your vestibular therapist would work on. Up here in the left corner with the woman, she's doing a vestibular ocular reflex. So she's working on driving up that vestibular reflex and getting her eyes and head to move together. Over here in the corner, he's doing a sit to stand, but he's doing it in a graded manner. So if you have orthostatic hypotension, we want to move in a slow manner through different transitions so we don't have the bottom fall out with your blood pressure. Down here in the corner, he's walking with head turns. So he's habituating, trying to work on desensitization of some movements that may be triggering. Here in the center, he's standing with his feet together. So he's working on substitution and general balance. And then down in the corner, that's a habituation exercise or trying to desensitize to a movement like bending over in order to not have it be as triggering. The big thing is when you go see a vestibular therapist, they will put together a personalized treatment plan for you that includes these principles. So here we go. So kind of our treatment, right? So orthostatic hypotension, the biggest thing is going to be medical management. Talk with your physician about when you're taking your medications and if maybe there's something that can be changed. We're going to work on compensating for that. So whether the cause is dizziness or postural instability. And then we're also going to have graded exposure to a triggering activity. So if sit to stands are what cause you to be dizzy, then we're going to work on standing from an elevated position and then slowly work down so that it's not as triggering. Hydration is important. I know we hit on that. And then compression stockings, if it's approved by your doctor. The medication, if medication in general is causing dizziness, there's a conversation with your doctor. Excuse me, it's going to be a similar treatment for orthostatic hypotension. If it's vestibular migraines, then the first thing is medical management. We got to get neurology on board. We got to make sure that those migraines are well controlled, and then we can work on the dizziness and imbalance associated with them. We're going to look at your eyes and make sure that they're working the way they need to. Your ocular motor function is intact. Then we're going to work on your balance. We're going to work on your head and eye movement together, and we're going to work on compensation in order to preserve balance and maximize function. Bppv, that's a big one. So treatment for that is actually pretty easy once we know what it is. We're going to take you through a repositioning maneuver where we move your head in different positions. And what we're trying to do is get those little crystals back to where they belong, so they're not floating through the canals in your ears. And then we'll address any underlying imbalance issues. Something to note is that research has found a correlation, not a causation, but a correlation between low levels of vitamin D and recurrent Bppv. So that's a conversation to have with your doctor. If you feel that you keep having Bppv and maybe your vitamin D levels are low, then talk with your doctor to see if adding a vitamin D might help with that. But don't add it without talking to your doctor. With a TIA or stroke, treatment's pretty similar, kind of using those principles that we talked about, adapting, habituating, substituting, kind of really tapping into the vestibular function that you do have, and then compensating and substituting for the function that you don't have. And then with cognitive decline, it's going to be a lot of those same principles. We're going to try to improve your balance. We're going to try to improve your eyes and head moving together. And we're going to try to ultimately create those neuroplastic changes. Same thing for a central vestibular dysfunction. So recommendations moving forward. So if you have dizziness, talk with your doctor and see if you can get a referral to physical therapists who are experienced with treating neurologic conditions. Vertigo is considered a neurologic condition. So those therapists will have experience and training in treating dizziness and specifically vertigo. You can look for physical therapists who are neurologic certified specialists. So they've taken, they have extra hours and they've taken a board exam to be a specialist in neurology. And so they'll have even more experience with treating neurologic and vestibular conditions. Home exercises are hugely, hugely important for this population. I know every physical therapist says that, but honestly, those of my patients that do the exercises get better so much faster. They don't have to come see me as long. And, you know, if you can just make it a part of your routine, you will not have to go see your PT as long, and you will feel better sooner. And then the last thing is the use of an assistive device, a walker, cane, sometimes gets, you know, poo-pooed on. But the best thing about those is what we're trying to do is maximize your function and independence. We want you doing as much as you can for as long as you can. So if that means you have to use a cane, but you can do everything you want to do by yourself, you don't need help, and you're safe and you're not falling, then that cane is really giving you more independence. And so that's what we really try and stress with our patients. Finally, yeah, I don't think we're going to, the couple questions that I got emailed were, how long does treatment take? Depends on what the dizziness cause is. If it's a Bppv, usually in about 3 visits or less, we can get that cleared up. If it's another cause, we usually see folks about 6 to 8 weeks, just depending on how their dizziness evolves. And yeah, that was one of the big ones I got. And then if you need to find a vestibular physical therapist, you can go to APTA.org, American Physical Therapy Association.org, and the search bar, look for neurologic physical therapists. Here's my email. If you have any questions or anything afterwards, please feel free to shoot me an email and I'd be happy to get back to you. And that's all I got.
All right, Kate, that was great. Thank you so much for that presentation, really informative. And thanks for addressing the question of where does someone find someone just like you in their communities? Because I was looking through the Q&A, and we have people from Canada, we have people from Texas, you know, Missouri, all over the place. So we're excited to have so many people joining us today. And I just have a few last minute announcements before you guys take off. I know we've run over, so I really appreciate you being here today. Again, thank you so much to our presenters. Dr. Kurek, Dr. Lewis, you guys were wonderful. And thanks to all of our attendees joining us from all over, literally all over the country. We'd also like to thank our program sponsor again, Theravance, for their support of today's event, as well as the Light of Day Foundation for their support of our PD Health at Home virtual program series. Today's session has been recorded and will be archived on the Parkinson's Foundation YouTube channel within a few days. We'll also be sure to send you guys a link to that recording, as well as an evaluation that we'd love for you to complete, so we know how to improve these programs moving forward. If you did have a question today that was not answered, please reach out to our toll-free helpline at 1-800-4PD-INFO. You can also email our Parkinson's specialists at helpline@parkinson.org. You can use that same contact information to order free resources, educational books, and of course, our Aware and Care hospital safety kit. So thank you again for joining us, and stay safe.